Today, let's talk about a clinical scenario you will definitely encounter: acute back pain. It's common, it's sometimes deceptive, and as healthcare providers, we need to get it right, because missing the red flags can cost a life, and overreacting can waste valuable resources. Acute back pain is incredibly common. Around 60% of the population will experience it to a significant degree during their lifetime. It usually presents in young to middle-aged adults. The classic story? Someone lifting something, poor posture, twist and snap, pain begins. But before we assume it's mechanical, we need to ask the right questions. When a patient presents with sudden onset back pain, here's what I ask every time. When did the pain start? Was there a lifting incident or some trauma? Where exactly is the pain? What does it feel like? Sharp? Dull? Burning? What makes it worse or better? Is the pain shooting down the leg? Think sciatica. Are there any neurological symptoms, especially bowel or bladder involvement? Have they had this before? And finally, any chronic conditions, particularly steroid use? This could point us to something more structural or sinister. A good history gives you 80% of your diagnosis. But now let's go to the physical exam. Start simple, observe how they move. Are they stiff? Guarded? Now, palpate the spine and paraspinal muscles. Any tenderness? Check lumbar spine mobility both while the patient is standing and supine. Next, let's assess for sciatic nerve involvement using the straight leg raise. Raise one leg passively. If pain occurs in the back, thigh, or calf, record the angle. A normal straight leg raise is usually 80 to 90 degrees. Dorsiflex the foot. Pain reproduced? That's a positive test. Flex the knee. Pain should ease. That's your confirmation. Then go deeper. Look for sensory deficits in the legs. Check motor strength, especially ankle dorsiflexion and toe extension. Test deep tendon reflexes. And don't forget the perineum. Sensory loss here or a lax anal sphincter could indicate cauda equina syndrome. Also consider checking pre- and post-void bladder volumes if there's any concern about urinary retention or overflow incontinence. So, most of the time, we're dealing with mechanical low back pain. That means pain worsens with movement, especially in certain directions. But here's the critical distinction: global pain with all movements? That's a red flag. Here are the red flag features you must not miss. Age under 20 or over 55 with new onset pain. Severe, worsening pain at rest. Bilateral sciatica. Thoracic spine pain. Obvious deformity. Neurological symptoms. Urinary or bowel issues. Systemic features: weight loss, fever, malaise. History of cancer, HIV, intravenous drug use, or steroid use. Each of these warrants further investigation and often urgent referral. Let's talk imaging. Plain X-rays are rarely helpful in younger patients unless trauma is involved. But for older men or postmenopausal women, consider vertebral collapse due to osteoporosis or even malignancy. The tricky part? Differentiating new collapse from old. Plain films often can't do it. That's when you bring in MRI or advanced imaging. In conclusion, always start with a focused history. Be thorough in your neuro exam. Recognize red flags early. Don't over-rely on imaging. And never miss cauda equina syndrome. Time is spinal cord. Acute back pain may be common, but your clinical judgment is what keeps it safe.